What is non-muscle invasive bladder cancer? Non-muscle invasive bladder cancer is found in the tissue that lines the inner surface of the bladder. The bladder muscle is not involved. Bladder cancer is the sixth most common cancer in the United States. Nearly 81,000 people will be diagnosed in the United States with bladder cancer in 2020. Bladder cancer is more common in males than females. 4 times more men than women tend to get this disease. Bladder cancer is more common as a person grows older. It's found most often in the age group 75 to 84. More Caucasians than any other ethnicities seem to develop bladder cancer. However, there are more African Americans who do not survive the disease. Now, what is cancer? Cancer is when your body's cells grow out of control. When this happens, the body cannot work the way it should. Most cancers form a lump called a tumor or a growth. Some cancers grow and spread fast, others grow more slowly. Not all lumps are cancers. Cancerous lumps are called malignant tumors. Now, what is bladder cancer? The bladder is where the body stores urine before it leaves the body. Urine is what we call the liquid waste made by the kidneys. The bladder is a hollow organ in the pelvis with flexible muscular walls. The bladder can get bigger or smaller as it fills with urine. Urine is carried to the bladder through tubes called the ureters. When you go to the bathroom, the muscles of your bladder will contract. They then push urine out through a tube called the urethra. When cells of the bladder grow abnormally, they can become bladder cancer. A person with bladder cancer will have 1 or more tumors in his or her bladder. Now, how does bladder cancer develop and spread? The bladder wall has many layers, made up of different types of cells. Most bladder cancers start in the urothelium, or the transitional epithelium. This is the inside lining of the bladder. Transitional cell carcinoma is cancer that forms in the cells of the urothelium that lines the inside lining of the bladder. Bladder cancer gets worse when it grows into or through other layers of the bladder wall. Over time, the cancer may grow outside the bladder into tissues close by. Bladder cancer may spread to lymph nodes nearby and others far away. The cancer may reach the bones, the lungs, or the liver, and other parts of the body. With non-metastatic bladder cancer, the tumor will not have spread outside of the bladder. Symptoms. How do you know that you have bladder cancer? Some people may have symptoms that suggest that they have bladder cancer. Others may feel nothing at all. Some symptoms should never be ignored. You may need to talk to a urologist about your symptoms. A urologist is a doctor who focuses on problems of the urinary system and male reproductive system. Talk to your doctor if you have the following symptoms: hematuria or blood in the urine. This is never normal. The most common symptom, often without pain. If you see blood in the urine, go to the doctor. Frequent and urgent urination. Now, this could be from a number of things, but still it's important to let your doctor know if suddenly you get frequent or urgent urination. Pain when you pass urine. This also is never normal. Make sure that you go to your doctor if you have that symptom. Pain in your lower abdomen or back. This could be from a number of things, but also you should let your doctor know if you have those symptoms. Symptoms you should not ignore. Blood in the urine. It's the most common symptom of bladder cancer, and generally it's painless. Often you cannot see the blood in your urine without a microscope. If you can see blood with your naked eye, you should tell your healthcare provider immediately. Even if the blood goes away, you should still talk to your doctor about it. Blood in the urine does not always mean that you have bladder cancer. There are a number of reasons why you might have blood in the urine. You may have an infection or kidney stones, but a very small amount of blood might be normal in some people, but not usually. Frequent urination and pain when you pass urine are less common symptoms of bladder cancer. If you have these symptoms, it's important to see your healthcare provider. He or she will find out if you have a urinary tract infection or something more serious like bladder cancer. Now, what causes bladder cancer? People can get bladder cancer when they come into contact with tobacco or other cancer-causing agents. There are also some risks related to genes and certain types of infections. Another known risk factor is a type of radiation beam aimed at the pelvis. Patients with other cancers, such as lymphomas and leukemia, who receive treatment with the drug cyclophosphamide may also be at higher risk for bladder cancer. But smoking is the biggest risk factor. You're more likely to get bladder cancer if you smoke or breathe in tobacco smoke. Smoking tobacco may be the cause of half of all bladder tumors. If you smoke, you are more likely to get bladder cancer than those who have stopped smoking. Workplace exposure is another known cause. Some things in the workplace may put you at greater risk for bladder cancer. Contact with chemicals used to make plastics, paints, textiles, leather, and rubber may also cause bladder cancer. How do we diagnose bladder cancer? Your healthcare provider will first perform a full medical history and physical exam, and they may refer you to a urologist for more tests and to form a diagnosis. If your diagnosis is bladder cancer, additional tests will find out the stage of your disease. It will also give your doctor an idea of what treatments are best for you. Some of these tests are described here. First of all, urine cytology. The color and content of your urine will be checked, and this test will also look at the actual cells under a microscope to look for cancer cells. Blood tests. A comprehensive metabolic panel includes kidney and liver function tests, and that will be among the blood tests that your doctor will order. A CT scan with a bladder cystoscopy are often good enough to diagnose bladder cancer. A CAT scan with a bladder scope or cystoscopy are often good enough to diagnose bladder cancer. Cystoscopy. A urologist will use a thin tube that has a light and camera at the end of it to pass through the urethra into the bladder. It allows your doctor to see inside the bladder cavity. Usually your doctor will use a flexible cystoscope and a local anesthetic for your exam in the office. The doctor will take a tissue sample with a cystoscope in the operating room. Taking the tissue at this time will allow your doctor to look at the cells. The tissue sample will be sent to a laboratory where they will find out the stage of your cancer. This will help with choosing the right treatment. Rigid cystoscopy is a scope that the doctor uses when you are put to sleep, and it's not flexible like the one used in the office, but rigid. This means that it's straight and does not bend. This cystoscope is bigger and has a light at the end and surgical instruments that can pass through it. This allows for more extensive work like a transurethral resection of a bladder tumor described below. Now, if any of these tests suggest that you have bladder cancer, the next step to confirm the diagnosis is a transurethral resection of a bladder tumor, also known as TURBT. You will likely be put to sleep for this procedure. During a TURBT, the doctor will both try to remove all visible tumors and take tissue. The tissue samples will be sent to a laboratory where they will find out important information about your cancer. They will also see whether the cancer has spread, and this will help with choosing the right treatment. The TURBT is a very important procedure for accurate tumor typing, staging, and grading. Your doctor can look inside the bladder, taking tumor samples and resect or cut away what he or she sees of your tumor. blue light cystoscopy with TURBT. Now for this test, your doctor uses a catheter to place an imaging solution into your bladder through your urethra. The solution is left in the bladder for about an hour. The doctor then uses a cystoscope to inspect the bladder with regular white light and then with blue light. The bladder cancer cells show up better with blue light. Other additional imaging tests, and these tests may help your doctor diagnose and stage bladder cancer. Retrograde pyelogram. This test uses x-rays to look at your bladder, ureters, and kidneys, and this test is done during the cystoscopy while you're asleep. An MRI. These tests use powerful magnetic fields, radio waves, and a computer to produce detailed pictures of the inside of your body, especially your kidneys, ureter, and bladder. Grading and staging. Grade and stage are two important ways to measure and describe how cancer develops. A tumor grade tells how aggressive the cancer cells are. A tumor stage tells how much the cancer has spread. Now, tumor grading is one of the ways to know if the disease will come back. It also tells us how quickly the cancer may grow and or spread. Tumors can be low or high grade. High grade tumor cells are very abnormal, poorly organized, and tend to be more serious. They are the most aggressive type. Tumor stage. The tumor stage tells us how much of the tissue has the cancer. Doctors can tell the grade and stage of the bladder cancer by taking a small sample of the tumor. This is called a biopsy. A pathologist in a lab examines the sample under a microscope and determines the grade and stage of the cancer. The stages of bladder cancer are TA, the tumor on the bladder lining that does not enter any layers of the bladder. TIS, or carcinoma in situ, a high-grade cancer but flat. It looks like a reddish velvety patch on the bladder lining, and because it's high grade, it tends to be more dangerous. T1, the tumor goes through the bladder lining into the second layer, but does not reach the muscle layer. T2, now this is where bladder cancer becomes more aggressive. The tumor grows into the muscle layer of the bladder. So in the superficial layer, TA and T1, there are no blood vessels or lymphatics, so that there's very low risk of your cancers going out throughout the rest of your body. But once the bladder cancer goes into the muscle layer, a T2, T3, or T4, then your risk of metastatic bladder cancer or cancer that goes throughout the rest of your body is much higher. So a T2 tumor is a tumor that grows into the muscle layer of the bladder. A T3 tumor is a tumor that goes past the muscle layer into tissues surrounding the bladder and usually fat surrounding the bladder. And T4, the tumor has spread to nearby structures of the bladder, such as the prostate in men or the vagina in females. Now, what does non-metastatic bladder cancer look like? Bladder cancer is described by how far into the wall of the bladder the cancer has grown, which is the clinical stage. Non-muscle invasive bladder cancers are found in the inner layers of the bladder. These cancers do not invade the muscular wall. These tumors are staged from TA, lowest stage, to T1. Over half of patients with low-grade TA cancers will have a tumor recurrence, and this is really important. That's why you have to have follow-up cystoscopy with bladder cancer. About 6% will progress to a higher stage. Higher grade T1 cancers recur at a rate of about 45%, and 17% of these will probably progress to a higher stage. So 3 times as many T1 cancers will progress to a higher stage than TA. Once diagnosed, the rate of survival are quite favorable for patients with non-metastatic bladder cancer. Survival in high-grade disease ranges from about 70 to 85% at 10 years, and a much higher rate for lower grade disease. However, it's important that the disease is diagnosed early. This helps doctors predict the course of the disease and choose the best treatment to stop it from growing. A cancer diagnosis can be very frightening. However, your doctor and medical team are there to help you. Talk with your healthcare team about all the available forms of treatment. They will tell you about the possible risks and the side effects of treatment on your quality of life. Your options for treatment will depend on how much your cancer has grown. Your urologist will stage and grade your cancer and assess the best way to manage your care considering your risks. Risks are classified as low, intermediate, or high and suggest the likelihood of tumor recurrence and/or progression. Treatment also depends on your general health and age. Treatment options for non-muscle invasive bladder cancer include cystoscopic transurethral resection of the bladder tumor, intravesical chemotherapy, and surgery. If the doctors fail to treat your cancer, your doctor will recommend removing the complete bladder. TURBT, transurethral resection of bladder tumor, is usually done under anesthesia. The surgery is done through the urethra using a cystoscope, so there's no cutting into the abdomen, and you'll be given general or spinal anesthesia so you won't feel anything. A rigid cystoscope is what your doctor will use for this procedure. This scope is straight and does not bend. It has a light at the end and is bigger and allows surgical instruments to pass through it. Your doctor is able to see inside the bladder, take tumor samples, and resect or cut away the tumor. If a tumor is clearly seen, the doctor will attempt to remove it all. The doctor will also remove very small samples of other areas of the bladder that may look abnormal. These samples will also be checked for grade and stage. You'll be left with a Foley catheter in your bladder after this procedure to allow your bladder to heal. You may need to have a TURBT more than once to remove all potential tumor. During your follow-up examinations, your doctor will check to make sure all the cancer is removed. Some patients need intravesical therapy. Intravesical means within the bladder therapy, and it's when a treatment drug is put directly into your bladder. The drug is put into the bladder with the help of a catheter, a thin tube that's placed through the urethra. You will hold the drug in your bladder for 1 to 2 hours and then pass it out. Intravesical chemotherapy is usually given immediately after surgery. Now that's to be differentiated from intravesical immunotherapy. Immunotherapy is a treatment that boosts the ability of your immune system to fight the cancer. BCG is the immunotherapy drug that is used for bladder cancer. Your BCG therapy will probably last about 6 weeks for the first course, and it's usually done in your doctor's office, not in the hospital or the operating room. You may get BCG treatments more than once, and some patients may need courses. The BCG drug is inserted into the bladder through a catheter. The therapy triggers the immune system to attack bladder cancer cells. It is one of the most effective treatments for bladder cancer, especially carcinoma in situ. It's not recommended if you have a weak immune system or certain symptoms. Side effects can include frequent urination, pain with urination, flu-like symptoms, joint pain, fevers or chills, or bacteria infecting the whole body, but this is much less common. You also may receive intravesical chemotherapy. Now, intravesical chemotherapy is usually given immediately after surgery. With intravesical or inside the bladder chemotherapy, drugs that are known to kill cancer cells are placed directly into the bladder. not in the bloodstream. As a result, many common side effects of chemotherapy, like hair loss, can be avoided. Because the drugs only reach the bladder lining, this type of treatment is only recommended for non-metastatic bladder cancer. Mitomycin C and gemcitabine are the most common chemotherapy drugs used for intravesical therapy. It is usually given after the initial TURBT. It helps stop cancer cells from going to another place and growing. It also reduces the recurrence rates. It can also be given as a 6-week induction course similar to BCG, and some people need more than one course. Common side effects include frequent urination, painful urination, flu-like symptoms, and skin rash. Now, some patients may respond to therapy if the cancer returns. If you have high-grade Ta or T1 cancer or carcinoma in situ, or you tried BCG and it didn't work, you may need something else to control the cancer. In this case, you should talk to your doctor about surgery to remove the bladder. Maintenance intravesical therapy. After the bladder is free of disease, your doctor may suggest more treatment with the same drugs to keep the tumor from coming back. This may happen at the first 3-month appointment after treatment. Maintenance therapy is a good choice for people who have had BCG, less so for those who have had chemotherapy drugs. It's given for up to 3 years after treatment, and generally about every 6 months for 3 weeks at a time. Your doctor will talk to you about whether you are a candidate for maintenance therapy. He or she will also talk about whether intravesical chemotherapy or BCG are good options for you. This is Dr. Judson Brandeis coming to you from Hive 80. I'm a physician advisor and a member of Hive 80. I hope you tune in for other topics.